Welcome to this first part of the lesson on immunology in our course on physiological regulating medicine. This is a lesson that I take great pleasure in giving, with great interest, because it has been the object of my studies of recent years, and you will be able to find several considerations, several deductions that are entirely original, some of which I shall be reporting for the first time during the course of this lesson. I think I have understood and also been able to observe in clinical practice, because it is my job to see patients every day, that it is extremely important to draw a distinction between the immune diseases. I mean to say that autoimmune diseases must first be understood and differentiated. In the field of autoimmune diseases, we have two major categories: the systemic autoimmune diseases and the localized autoimmune diseases. So, first of all, we must ask ourselves this question when dealing with autoimmune diseases. Is it a systematic or a localized autoimmune disease? Because the systematic autoimmune diseases have to do with the overexpression of the Th2 polarity in our immune system, while the localized autoimmune diseases correlate with and depend on an overexpression of the Th1 compartment of our immune system. This will help us to understand many things and to decide on a suitable therapy. The first diseases that we shall look into here is a disease that is very widespread today, although it is seen in various stages, i.e., it may be very severe in some stages and less so in others, and that is systematic lupus erythematosus. The words themselves make us realize that this is a disease that is mainly, at least in the most full-blown, most typical phase, a disease that is mainly with the Th2 expression. To fully understand this disease, it is important to study its epidemiology as well as its physiopathology. In the case of systemic lupus erythematosus, it is interesting to note that this occurs more easily in women, more readily in their fertile period, so it is a disease typically correlated with the female sex hormones. This is an aspect that we must bear carefully in mind. The other element to consider is what happens at hematological level. In this disease, we shall see that it is very often a lymphomania, and therefore a reduction in the number of lymphocytes, and a great deal of lymphocyte-destroying activity. There is consequently an aggression, an autoaggression against the effector cells of an immune system. How does all this happen? The female sex hormones, estrogen and progesterone, have a key part to play. Because of their immunity driving action, they predispose women to the development of diseases of autoimmune aggression. When the body comes into contact with trigger factors, such as an infection or exposure of ultraviolet radiation, we must remember, for instance, that the stupid habit of suntanning with ultraviolet radiation beds very often leads to the rupture of the cell structures and our cell's DNA that can prompt the production of antibodies. Nowadays, we are increasingly frequently seeing the onset of lupus, not only in relation to estrogen and proestrogen therapies, i.e. contraceptive pills, but also in relation to the exaggerated use of UVA and UVB sun tanning lamps. It may be important to know, for the purposes of prevention, that this practice can facilitate the explosion of lupus in predisposed subjects. Another very important issue that we need to know is that there is a cytokine in this disease, a Th2 cytokine, that is typically overexposed in lupus, and this is interleukin-10. In theory, we could experimentally induce a situation similar to a case of symphic lupus erythematosus by administering interleukin-10. Or we could inhibit the clinical expression of the disease by inhibiting interleukin-10. This makes us see how important it is in this specific disease to work on a particular interleukin, because it is important in this disease to try to reduce the impact of the Th2 interleukins, and of interleukin-10 in particular. A very interesting feature, and I might even add that this is the only disease in which I have noted, is that in lupus, however, There is a relative reduction, but a reduction nonetheless, in the Th1 interleukin that very often poses important problems for other types of patients. And that is the tumor necrosis factor alpha. This is an interleukin that usually causes severe damage at tissue level, but that is lacking in this disease. And the problems with lupus mainly concerns this increase in interleukin 10 instead. So what must we do with this disease from the therapeutic point of view? The fundamental concern is to block the abnormal inflammatory process, so the basic drug will be gunaflam, administered routinely at a dosage of 20 drops morning and evening, even for very extended periods of time, monitoring the anti-nuclear antibodies in the laboratory. The level of the anti-nuclear antibodies will tell us whether disease is regressing or not. The other drug that is very important is Guna matrix, because it is a question of dealing with the abnormal inflammation of the extracellular matrix. So we must work specifically to cleanse the extracellular matrix, and we will therefore need 20 drops of Guna matrix, morning and evening, here again to be taken like the gunaflam for a very prolonged period of time, while carefully following up the evolution of these anti-nuclear antibodies, which are specific markers of this disease. Based on what we have said so far, a very interesting consideration comes to mind in the area of PRM. We will find that the patient improves in normalcy if we stimulate the male phase of the hormone, and therefore if, in a sense, we shift the balance from the female hormone attitude towards the male hormone attitude. It is important in such cases to use Guna male, specifically because we need to shift this quid. So, in women too, we need to try to shift the balance more in favor of progesterone, of the more masculine hormone. Finally, small amounts of tumor necrosis factor alpha are extremely important to this disease, stimulating the Th1 aspect and consequently helping to restore the balance of the immune system. This is a great novelty because it is one of the very few circumstances in which such an important inflammatory cytokine as tumor necrosis factor has a therapeutic role instead of a pathogenic one. We shall use 10 drops of tumor necrosis factor alpha 4C morning and evening, again for extended periods of time. In the context of the autoimmune diseases with the Th2 polarity, there is a role, a very important place for a disease that is being seen with some frequency, and that is scleroderma. Scleroderma is a disease that causes an increase in the fibrotic tissues in the extremities, but also on a level with the face, the mouth, and so on. So, with time, the patient has circulatory problems in the extremities of the limbs, but also important deformities on the level of the facial mass, with lip retraction, and so on. This is consequently an extremely invalidating, extremely complex disease that has devastating effects on the body. Here again it is important to understand first of all that it is the Th2 disease, and already understanding this aspect may help us to see how to restore the balance. But in the context of the Th2 diseases, scleroderma is a very particular condition. There is an increase in the levels of interleukin 4, an increase in the connective tissue growth factor, an increase in the transforming growth factor beta, and so on. I.e., in the context of this type of disease, scleroderma has a particular feature that distinguishes it from all other diseases, and this very peculiarity is what we also find at clinical level. In fact, on clinical examination, we shall see, for instance, that there are very often esophageal and gastric problems that we do not encounter in any other diseases. There is a problem of typical calcinosis on a level with the skin and so on, so it is a very typical disease. In scleroderma, the basic drugs to use, and by that I mean to use for lengthy periods of time, because this is a disease that often comes under our observation when it is already in an advanced stage, when there are already problems involving the hands and face, so the therapy must naturally be prolonged. Either we take action at a very early stage, identifying this disease, which is revealed in the early stages of Raynaud's disease, and consequently with the classic symptoms of cold hands, extremely cold, and catatonic extremities with a minimal drop in temperature. Either we identify it already at the stage, or otherwise we have to implement an extremely prolonged therapy that is unfortunately not always effective. However, the basic drug for scleroderma 2 is Gunamatrix. We shall use 20 drops of Gunamatrix 2 or 3 times a day for a lengthy period of time. This will be associated with Gunalympho, again at a dosage of 10 to 20 drops 2 to 3 times a day, and again for a lengthy period, so these are the 2 basic drugs. Then we have another extremely interesting drug, always in our PRM armamentarium, called anti-age skin, and we shall administer 3 to 5 granules twice a day. As for the cytokines, on the other hand, which is the cytokine characteristic of scleroderma, it is an interleukin-2. Interleukin-2, we must remember, it is one of my favorite interleukins, is the interleukin of tissue renewal, of cell renewal. It is the interleukin that has the same structural characteristics as the growth hormones that have a tropic effect at tissue level. Scleroderma is a disease that tends to introduce tissue atrophy. So it is clear that the fundamental role played by interleukin-2 lies in relation to its tropic effect. So, 20 drops of interleukin-2 4C morning and evening go to complete the therapeutic protocol for this disease, together with the other 2 drugs, Gunamatrix above all and Gunalympho.
Suo effetto trofico. Quindi le 20 gocce di interleuchina 2 mattina e sera vanno a completare la patologia di fondo di questa
Another autoimmune disease, which is again Th2 and again systemic and consequently always very important, is Sjogren's syndrome. This disease is also extremely common. Unfortunately, we are seeing autoimmune diseases very often than we might expect, although they are underestimated. A typical symptom of Sjogren's disease is dryness of the eyes or dryness of the mouth. How many patients use lubricant eye drops? This dryness of the eyes is very often the expression of a syndrome that may not be expressed in a particularly severe way, but it is nonetheless the possibly incomplete expression of this autoimmune syndrome, which always has a Th2 polarity, which takes the form of a dryness of the mouth, the eyes, the joints, i.e., a dryness even at intra-articular level, often capable of causing a marked sense of fatigue. Pathognomic symptom of this disease, as we said before, is dryness. During our clinical examination, we shall ask patients to show us their tongue, and we shall see an extremely dry tongue, an extremely arid mouth. As we said, we are dealing here with a type Th2 disease, and the effector of this disease is an interleukin-6, i.e., it is an overexpression of this interleukin-6 that causes the onset of this disease. So the basic drug to use will always be Gunamatrix, which contains the small quantity of interleukin-6 that is needed to modulate, in a sense, the overexpressed interleukin-6 of this disease. So Gunamatrix is the best drug that we associate in this case. With Guna Cell, we shall prescribe 20 drops morning and evening in both, and here again, they may need to be used for a very prolonged period of time according to the symptoms, ocular, oral, or so on. If there is a concomitant joint involvement, we should associate 1 tablet of ZLT 2 or 3 times a day, and for the therapeutic point of view, which is the cytokine involved in Sjogren's syndrome, the cytokine of interest in this disease, and that has a profound impact at immune level is interleukin 7. Interleukin 7 4C, which is an interleukin that globally stimulates the immunocomponent cells and consequently, in a sense, it corrects the immunobalance in these patients. It is an interleukin specific for this disease, and we shall use it at a dose of 20 drops 2 or 3 times a day, depending on the severity of the symptoms, and also associate it in the same glass and at the same time with guna matrix and guna cell. The various drugs that constitute the therapeutic protocol can almost always be administered together, thus obtaining the effect of a synergetic amplification that is extremely interesting. Rheumatoid arthritis is a highly complex autoimmune disease that is very common and that we must treat extremely carefully. What's more, it is not easy to classify as a Th1, Th2 disease. We have seen before that the Th2 autoimmune disease is typically a generalized disease and that the Th1 is typically a localized disease. Well, rheumatoid arthritis goes through a first phase in which it becomes manifest as a localized disease. It affects the smaller joints of the fingers. It affects the shoulder. It affects the ankles, and so on. But very often, with time, it evolves into a generalized Th2 disease, so the therapeutic strategy must be differentiated, in a sense, considering both the patient and the stage of the disease. As I said before, this is a very common disease that does not affect the bones, like osteoporosis. It affects the synovial cartilage, and it very often leads to deformities and even disabilities in these patients, who may sometimes even be very young, and are mainly of female gender, because the autoimmune diseases are almost always more common among females, who have a more active and more reactive immune system even in disease. In this disease, we see a typical overexpression of all the pro-inflammatory cytokines, and particularly tumor necrosis factor alpha, interleukin 1, interleukin 6, interleukin 8, and so on. And among other things, rather oddly, we shall also very often see an increase in the Th2 interleukins. In other words, there is a generalized overactivation. This is very strange, and we wonder how it is possible for there to be an alteration even of the interleukins that have a tendency to block inflammatory reactivity. This is explained by the fact that very often there is an increase in interleukin 10 that blocks inflammation, but it is only a compensatory increase. It does not really succeed in blocking the pain, the inflammation, and the progression of disease. So this is the element that may explain the apparently strange trend of the disease. In this disease, we must first understand whether the problem is mainly the inflammation, i.e., the extent of the inflammation, and in this case we must inhibit the overexpressed cytokines. For instance, one overexpressed cytokine in these situations is interleukin 1, and we must therefore take action if the problem is mainly an inflammatory problem. With the anti-interleukin 1 4C, 10 to 20 drops 3 or 4 times a day. Or we must establish whether the anti-inflammatory response that would be physiological on the part of the body is insufficient, in which case we have to stimulate the TGF-beta and interleukin 10 that have an anti-inflammatory capacity, but that in this case is not sufficient. But we must understand which of the two strategies we need to use in our patients, very often of female gender. We must remember, too, that tumor necrosis factor contributes to activating certain specific cells, i.e. osteoclasts, which progressively destroy cartilage, that unfortunately tends not to be regenerated, and the osteoclasts slowly destroy the joint completely. Why do I say this? Because it is extremely important in this disease to take action early and to try to save as much cartilage as possible. So it is not possible to hesitate. We need to take action as early as possible. This means that it is important to achieve a timely diagnosis, and it is essential to begin the therapy immediately. So basically, what happens? What is the pathogenic pattern? In this disease, the first inflammatory stimulating element will be interleukin-1. Interleukin-1 activates the cascade of inflammatory prostaglandins. In addition, the interleukin-1 stimulates the tumor necrosis factor alpha. That, in turn, goes to stimulate the metamorphosis that subsequently damaged the cartilage. But this is not the end of it. Tumor necrosis factor is also capable of stimulating interleukin-6, an interleukin of both type Th2 and type Th1, responsible for the expansion of disease. The disease passes from the localized Th1 phase to the generalized Th2 phase, which means systemic symptoms. That means fever, loss of muscle mass, weight loss, and so on. So we must seek to contain this progression and at the same time to understand whether the disease is still in the Th1 phase or if it has already progressed to the systemic Th2 phase. We need to understand this clinical stage of the disease clearly. The other aspect that is important to understand is the exact role of the cytokines. As we have seen before, we have cytokines that are pathogenic for bone destruction. We have seen interleukin-1, tumor necrosis factor alpha, and we have cytokines that the body activates to defend itself. As we were saying earlier, against inflammation and bone destruction, that we must seek to sustain. Which ones are they? Interleukin-4, which always has a trophic effect on the tissues. Interleukin-10, which is an anti-inflammatory agent, and in this case, specific for rheumatoid arthritis. A cytokine that is usually aggressive, but that protects the cartilage bone aspects is interferon gamma, that we must use in the more advanced IETH2 forms of the disease. So it is always fundamental to distinguish the clinical evolution of the condition. What shall we use for this disease? It is essential to restore to injection treatment subcutaneous injections of PRM drugs for infection. Among these, the one that stands out in the case of the rheumatoid arthritis is guna polyarthritis. It would be ideal to take action right from the early stages of the disease, with one injection of guna polyarthritis once or twice a week at the sites of inflammation. As a basic drug, to be given orally, 20 drops twice a day. We shall use guna matrix even for considerable periods of time, and we shall obviously always associate it with guna flam. And what about the cytokines? For the cytokines, we must understand the stage of the disease. Early stages of the disease require anti-interleukin-1 4C, which is already contained in guna polyarthritis anyway. But we shall also administer this orally to potentiate the effect of the therapy. If the rheumatoid arthritis is already in an advanced stage and there is already evidence of systemic symptoms, loss of muscle tissue, fever, and so on, it is no longer sufficient to give anti-interleukin-1 4C alone, which we shall certainly continue to administer. But we need to associate it with interferon gamma 4C, 10 to 20 drops again, twice a day, to stop the destructive pathogenic effects of the disease on a level with the bone.